Hi, everyone. Welcome back to Medology. Today, we're diving into the fascinating world of cholinergic drugs, medications that play a key role in how our nerves communicate with each other. Whether you're a medical student, a healthcare professional, or just someone curious about how these drugs work, you're in the right place. So, let's get started. In the video shown here, I've already explained the cholinergic and autonomic systems in detail, but here I just want to give you a quick recap. The neuron you're looking at is a preganglionic neuron from the parasympathetic nervous system, originating in the central nervous system. This neuron connects to a postganglionic neuron at the ganglion and releases acetylcholine from its terminal. That acetylcholine binds to nicotinic receptors on the postganglionic neuron. When these receptors are activated, ion channels open, allowing sodium to flow in and potassium to flow out, which causes the next neuron to depolarize. Next, the postganglionic neuron travels toward the target organ, where it once again releases acetylcholine from its terminal. This time, depending on the target tissue, acetylcholine can act on either nicotinic or muscarinic receptors. We've already talked about nicotinic receptors, but how do muscarinic receptors work? These receptors are linked to G proteins within the cell membrane. When activated, they trigger intracellular signaling pathways, leading to a variety of metabolic and functional changes inside the cell. So, to sum it up, when acetylcholine is released in the cholinergic system, it needs to bind to its specific receptors to produce an effect. These receptors come in two main types, nicotinic and muscarinic. The nicotinic receptors themselves are divided into two subtypes, NN, neuronal type, found on postganglionic neurons, NM, muscle type, located on skeletal muscles, and when activated, they can trigger involuntary muscle contractions. On the other hand, muscarinic receptors come in five types. M1, mainly found in the CNS, M2, located in the myocardium, heart muscle, M3, present in glands and smooth muscles, and finally M4 and M5, which also act within the CNS, although they're less commonly discussed. Now it's time to understand how drugs that affect the cholinergic system actually work. The diagram you see here shows a nerve terminal. Inside this terminal, acetylcholine is synthesized and stored in vesicles. When the neuron becomes active, these vesicles fuse with the membrane and release acetylcholine into the synaptic cleft. Once released, acetylcholine binds to its specific receptors on the next cell and produces its effects. But here's an important point. As long as acetylcholine remains bound to its receptor, its effect continues. So, the body needs a way to stop the signal, and that's where the enzyme acetylcholinesterase comes in. This enzyme breaks down acetylcholine, effectively ending its action. So we can summarize it like this. The more acetylcholine that's released, the stronger the cholinergic effects. The more active acetylcholinesterase is, the weaker those effects become. And this exact mechanism forms the basis for how most cholinergic drugs work. So, to enhance the activity of the cholinergic system, there are two main strategies. 1. Drugs that increase the release or action of acetylcholine. This is called the direct stimulation method. 2. Drugs that inhibit the enzyme acetylcholinesterase, allowing acetylcholine to stay active longer. This is an indirect stimulation method. On the other hand, to inhibit the cholinergic system, there are also two main ways. 1. Increasing the activity of acetylcholinesterase, which breaks down acetylcholine faster. 2. Blocking acetylcholine receptors, so even if acetylcholine is released, it can't bind or produce an effect on the target cell. So, all cholinergic drugs, whether they enhance or inhibit the system, work based on these same fundamental principles. Now that we understand how cholinergic drugs work, it's time to look at their clinical effects. In general, cholinergic drugs produce a characteristic pattern of symptoms, which can be easily remembered using the mnemonic dumbbells. D for diarrhea, increased bowel movement and loose stools. U for urination, increased urination. M for meiosis, constricted pupils. B for bronchoconstriction, narrowing of the airways and difficulty breathing. B, the second one, for bradycardia, decreased heart rate. E for excitation, stimulation of the central nervous system and skeletal muscles. L for lacrimation, increased tear secretion. S for salivation, increased saliva production. S, the last one, for sweating, increased sweating, or more generally, increased exocrine gland secretion. So whenever you hear about cholinergic drugs, the first thing that should come to mind is this dumbbells pattern. It nicely summarizes most of the key effects these drugs cause. As you can see, cholinergic drugs enhance parasympathetic activity, just like we discussed in detail in the previous video. Now it's time to move on to the main topic, the classification of cholinergic drugs and how each group is used clinically. Group 1, direct-acting cholinergic agonists. These drugs directly activate cholinergic receptors. Some of the most important ones include bethanechol, pilocarpine, carbachol, and varenicline. Each of these drugs differs slightly depending on which receptor type they stimulate and how strongly they activate it. That's why it's best to look at them individually so we can clearly understand both their clinical uses and exam-relevant points. Let's start with bethanechol. This drug stimulates muscarinic receptors in the bladder, causing contraction of the detrusor muscle and relaxation of the internal sphincter, which makes urination easier. It also stimulates muscarinic receptors in the gastrointestinal tract, increasing intestinal motility and digestive secretions. Clinically, we use bethanechol in patients with urinary retention or postoperative ileus, when the intestines don't start working properly after surgery. Easy way to remember, think betha equals bathroom. Bethanechol helps you go to the bathroom more easily. Next up is pilocarpine. This drug mainly acts on exocrine glands and the eye muscles. By stimulating muscarinic receptors, it increases the secretion of tears and saliva, which makes it useful in conditions like dry eyes and dry mouth, for example, in Sjogren's syndrome. It's also used in the treatment of glaucoma, a disease where intraocular pressure becomes elevated. This happens either because too much aqueous humor, the fluid inside the eye, is produced, or because the outflow pathway becomes blocked or narrowed. As the fluid builds up, pressure inside the eye rises, which can damage the optic nerve and potentially lead to blindness. Pilocarpine helps by contracting the iris sphincter and ciliary muscles, which widens the drainage channels and allows the aqueous humor to flow out more easily, thereby reducing intraocular pressure. Easy way to remember. Think pile of tears. Pilocarpine increases tear and saliva production. Now, let's move on to carbachol. This drug works in similar situations. It can also be used for glaucoma and to constrict the pupil. The main difference is that carbachol acts on both muscarinic and nicotinic receptors, so it may cause more side effects compared to pilocarpine. To help you remember, think carbachol. It acts on the eye for glaucoma and is cholinergic in action. Finally, the last drug in this group is varenicline. This drug is a partial agonist at nicotinic receptors, and it's most commonly used for smoking cessation. But how does it work? Since it's a partial agonist, varenicline binds to nicotinic receptors and activates them, but not fully. This produces a mild, satisfying effect, almost like the sensation from nicotine, but without the full pleasure of smoking. At the same time, it reduces withdrawal symptoms, making it easier for patients to quit smoking. Easy way to remember, think very clean lung. Varenicline helps you get a cleaner, smoke-free lung. Now, an important question. What are the side effects of these drugs? In general, cholinergic agonists don't have many unique side effects. Most of their adverse effects are actually extensions of their normal actions. In other words, the dumbbells effects. For example, a patient using pilocarpine for glaucoma may find that, although the eye problem improves, they also experience increased GI motility and more frequent urination because the drug can affect other muscarinic receptors in the body. On the other hand, a patient taking bethanechol for constipation might feel that their digestion improves, but they may also notice visual accommodation problems due to the drug's effects on the eye. So, side effects vary depending on the patient's condition and how widespread the drug's effects are. In most cases, these are mild and manageable if the patient is informed, but some can be serious, especially in certain diseases. Important precautions. Because these drugs can cause bronchoconstriction, they may be dangerous in patients with COPD or asthma. Due to increased gland secretion and gastric acid, they can worsen peptic ulcer disease. And because of bradycardia, they should be used with caution in cardiac patients. So while cholinergic drugs can be very helpful, their systemic effects mean that clinical context and patient condition are always crucial to consider. Thanks for watching. Hope this helped you understand the cholinergic system better. Don't forget to like and subscribe and hit the bell icon so you won't miss the next videos.